Hello, good morning from La Paz University Hospital from Madrid. I'm Alfonso Jurado. Beside me is Dr. Guillermo Galeote and Carmen. And here with us in the CAD lab are Patri Chus, our nurses, and in the control room, Daniel, Laura, and I don't know if anything else. So we have two cases today. The first one is an interesting coronary case, and Daniel Tebar is going to present you the clinical story.
Hi everyone, we are presenting a 51-year-old medical history of obesity and former smoking. He has diagnosis of atrial fibrillation. In 2020, he experienced a non-ST elevation in myocardial infarction with a left ventricular ejection fraction of 30%. The left anterior descending artery was occlusive and was treated with 2 drug-electing stents. He also has a dual-chamber implantable cardioverter defibrillator. In the current evaluation in 2023, the patient presents another non-STEMI episode. Further assessment revealed significant stenosis in the ostial left anterior descending artery, as well as the ostial median artery. An echocardiogram showed a decrease in left ventricular ejection fraction to 26%. The patient is currently prescribed clopidogrel and atenolol. The right coronary artery doesn't present significant lesions. The median artery and the left anterior descending artery shows an ostial lesion which appears to be due intra-stent restenosis. Intravascular ultrasound IVUS was performed, revealing a healthy proximal left main with a diameter of 5 millimeters. There is a slightly protrusion of the proximal stent in the left anterior descending artery. This stent exhibits proximal intra-stent restenosis, primarily due to underexpression. The plan is to perform angioplasty with stenting of the bifurcated left main coronary, guided by intracoronary imaging.
5x8.
So, Alfonso.
Okay, thank you, Dani. So this case is quite interesting in our point of view because of the controversial points of treating these lesions or not. The current setup is that we have done a radial approach, 7-in-6 as lender sheath with an EVU-7 French. And as Danny said, we performed the previous angiography, some measurements with IVUS in the LAD, but not in the intermediate branch. And I'm going to show you the angios of today and also some functional measurements. Stems from the ostial LAD towards the mid vessel. Probably these stents are quite small for this vessel. In the reports, these stents are 2.75 in the proximal part and 2.5 in the mid LAD. And you can see severe stenosis, in-stent restenosis or in-stent lesion at the ostium. And also there is a difficult to see lesion in the ostium of the intermediate branch. And this is the point. The patient is asymptomatic, but with severe left ventricular dysfunction. And we have performed some additional measurements. You can show, Laura, please, the DFR of the intermediate branch. Firstly, this is the value we have advanced. This is the comet wire advancing in the intermediate branch, and the value of DFR is 0.95. So now, as we supposed previously, this lesion is not producing any ischemia. We have maintained this wire here in the vessel that we are going to use as a jail wire if we treat left main LAD to analyze if we need to perform something in the branch, in the intermediate branch after the stent. And before the connection, we have done also some measurements in the LAD. We can show it. And surprisingly, we have this value of DFR in the LAD. The wire is has been advanced. I don't know if I have recorded it, but the wire is in the sensor in the mid LAD, and the value is 0.92. So this treatment is not for angina, but for optimization of the previous stents in a patient with very young patient with severe ventricular dysfunction. Additionally, we have performed today another IVUS with the Boston IVUS. And we can show the whole pullback. we have time. This is the distal part. If you are seeing distal to the stents, the vessel probably is 3.0, something like that. This is the stent, the 2.5 stent. Well opposed, but probably not adjusted one-to-one to the vessel. I know the exact point of the overlapping segment, probably is there. And the proximal one is 2.75. In the longitudinal view, at the bottom of the IVUS, you can see some stenosis more proximally. And the most interesting part, we're going to see it the whole run, but afterwards we can analyze frame by frame, is the ostium. So this is the part probably a little bit that expanded here. Here probably there is a calcified lesion there. Here probably there is a calcified lesion there. And now we are reaching the proximal part. Here is the problem, no? Mm-hmm. So we are. You can see a very big left main. Probably 5 is the measurement. We can analyze, Laura, please, the proximal part from the. This is the left main. Probably the reference diameter is 5, if you agree. And then if you follow distally, frame by frame, probably. No, distally in the to analyze the ostium of the LAD. Okay, proximally now, frame by frame, please. This is the proximal LAD, and you're going to see the wire in the left main at the 12 o'clock. There, stop. This is the wire of the intermediate branch, and probably the stent, the 2.75 stent of the LAD is protruding 1 millimeter and something, or 2 millimeters in the left main. Continue proximally, please. The circ is not well seen in this pullback because the orientation. This is the wire. This is the protruding struts in the left main. Not too many struts, but probably a small stent. So this is the controversial point. This is not producing ischemia right now. Yeah. Symptoms, but probably some of the dysfunction is related to the ischemia at this point. So our plan is to perform an optimization on the stents, probably from the distal part of the stents with a 3.0 NC balloon there, because the reference probably is 3.2, 3 more or less. Mm-hmm. And then to optimize all the stents at the proximal part, put another stent 3.5 to something, and doing a pot with a 5.0 balloon. Yeah. We cannot post-dilate the stent that is right implanted in the proximal LAD because it's a 2.75 stent, and if we go up to 5 millimeters, probably we are going to break the stent. And also we don't have enough length in the left main to post-dilate because it's only 1.5 millimeters. So yeah, this is our plan. And then we will analyze later the result of the DFR in the jail wire in the intermediate branch. Any comment, Guillermo?
No, I agree with you. But I don't know if it's necessary to pass another time the pressure wire across the stent of the left main.
After putting the stent?
Yes, because...
No, we have data of the jail wire that has published our friends from Cordoba in the Spanish Journal of Cardiology, and analyze a jail wire, not crossing again after putting the stent, a jail wire from the beginning. And these data are there, so we can analyze. If we need, we can cross again and compare the results. So we have the balloon, the 3.0 balloon, NC. Yeah. This is an NC emerge balloon, and we are going to cross it towards the LAD. Parina. Our nurses are taking care about the heparin because the patient is 120 kilograms. he stopped the anticoagulation or anticoagulation 48 hours before because we didn't know if we would need ventricular assist support. We have decided not to use it because the blood pressure is, you can see in the screen, 160 more or less. We have noradrenaline just in case we need it, but because of the possible complications in the femoral access, we are doing it for safety reasons without ventricular support. Okay, I am advancing the balloon without any difficulty towards the distal part of the stent. We can do a stent boost here probably, or probably a cine without contrast because I am there. No contrast, Carmen. I think I'm there, okay?
1 millimeter less?
Less,
because
proximal. Okay.
The previous
Okay. There.
Okay. Nominal is 12.
Mm-hmm. Okay.
So regular.
Okay, the expansion seems to be good. So we're going to optimize all the length of the stent. Probably we need a 3.5 for the proximal part, but probably with this balloon we can advance some work.
16 is 3.08. 16.
Okay, now we're trying to reduce also CNS because of the radiation. You know, with obese patients, this is going to be double from a non-obese patient. Okay.
18.
18, perfect. We're going to store the fluoro. Is there any question, Danny, from the audience, or
No.
it's too early? It's too early for.
Yeah, it's too early. There are no questions.
Okay, the expansion seems quite good.
20.
We're going to check again IVUS later on, so I'm going to save some fluoros and some cines. Okay. Okay. Vamos a tener un 3,5. 15. NC. Do you want me to dilate also the left main with this balloon?
Yes. Yes.
Okay, vale. The patient is tolerated everything quite well till now.
20.
Okay, hold on. Of course, you can do this PCI with a 6 French guiding catheter, but we, as the patient is quite big, we have decided to use a 7 French just in case we need a double stent technique or something. You need to have a plan A, B, C, and D in these cases. Okay, perfect. So let's do a fast dilatation in the left main and then go with the 3.5 balloon.
Ahí está. No sé si lo tenemos.
Pues rápida, 18. Luego vamos con el grande, ¿sabes?
Sobre todo no pillar la parte muy sana, ¿no?
Ok, vale. 15. So we have pre-dilated everything. I'm going to retrieve. The balloon is quite stuck because we have done several dilatations.
Pequeñotes.
Okay.
Pequeños solamente.
We are working in the air a little bit. Okay. Está un poco pegado a las guías. The balloon is quite stuck through the wires because these dilatations. No, tengo. I'm going to retrieve it slowly. This sometimes happens with the balloon and also with the OPN, and you have to be very cautious of not losing everything. Okay, the balloon is out. Let's check everything here.
Sí, que estén liadas.
Sí, pero como les quiero desliar aquí, no estoy tirando. Será más fácil cuando llegue aquí el rotor.
Tirando,
¿Eh?
Carmen. Tirando.
Tira. Ok. Vale.
Dejamos una compresa y
Vale.
compresa un
The
poquito.
problem is that we are in the air because the patient has a big leg. Okay. All the wires are there. Perfect.
Vamos a dar un tecito. A ver qué tal ha quedado la posición. Cuando tú me digas, ¿eh?
Dale, Tess. Okay. Here's the intermediate branch. Okay, well, I'm going to leave it there. Okay, so we are going to continue with 3.5.
Yeah.
Okay. With 3.5 balloon to dilate the proximal part of the stents and also the left main. No questions, Dani?
No, not any question.
¿Tenéis la guía? Okay. Vale, tengo ya. Okay, let's go. We have to decide the starting point to dilate with this balloon. Probably here, Guillermo? 3.5?
Yes.
Venga.
Nominal 12.
Nominal. And then we can go up at the proximal part.
12.
Okay, perfect. Expansion quite good. Okay, again. Vamos a poner la Nora 2. Nora.
16.
Okay, quite good. Por favor, Carmen. Vale, venga, dale. Vale.
Porque 18.
Vale, baja. ¿Qué tal?
Me duele un poco, ¿no?
Bien, si te molesta algo nos lo dices, ¿eh? Molesta un poquito,
Vamos a
¿no?
ver qué tal el flujo. Vamos a ver qué tal el flujo.
Dame un test, por favor. Okay, the flow is okay. The patient suffer a little chest pain, obviously, with this dilatation. Espera, que si no se me van a ir. Es que el problema es el desnivel aquí. A ver, ¿quién está?
Por ahí abajo, por si no.
Va mejor, como hemos llegado tan menos. I am removing the 3.5 balloon. Te quito aquí una.
Con las 3.
Ok, remove it. Ya está. Las tengo. Okay, so what do we do now? We can check again with the IVUS. We can implant the stent with the previous measurements and then IVUS afterwards. What do you think?
I think we can do an IVUS.
Okay, let's go with the IVUS.
Until now, ¿no?
Okay. Let's go with the IVUS.
Nitro, un poquito de nitro. ¿Podemos hidratarlo?
Nitroglicerina, por favor, Carmen. Nitro.
Nitro. The blood pressure is okay.
Ok, dale un poquito, sí.
Okay.
El alargado mediano. Lo voy a dejar ahí. Vale. Ok, ¿tienes la guía? Hold me the wire.
Un momentito.
Ok.
A ver, ¿dónde está la idea?
A ver, trae.
Tiene...
Tengo yo. Esta.
The wire is alive.
Sí, the wire is alive. Sí. Ok. Let's advance the IVUS to the lady. I don't know if any of you would have been considered to leave this lesion alone and do a conservative treatment, but with this image, with the angel on the IVUS and this left ventricular dysfunction in this patient, a very young patient, for us is better this approach. Okay, life in the IVUS, please. Okay, wait, pardon. Again, sorry, my fault. Pull back. Okay, let's see. This is the stent, quite bigger than before. Much better.
Mm. Yes.
We are reaching the proximal LED now. Calcified plaque.
Yeah.
But this has better expansion there. Now we are reaching the ostium in 10 millimeters, more or less. Let's see
Okay.
This is okay, much better.
Yes.
Okay, we can stop here and do some measurements again. Okay. This is the thing that we always discuss with the colleagues and in the congresses, because the IVUS is not, crossing the IVUS catheter is not magic. You need to interpret the results and also take decisions after that. So probably if you can do all the PCIs with IVUS or intracranial imaging, the results are going to be better. And we have now data about even clinical events, as you know, the improvement in prognosis using IVUS in this kind of procedures.
And we see the ostium another time, please, Laura. We see the ostium in this moment.
If you compare just the longitudinal view of this pullback than with the previous one, you can see there's a much difference. The ostium is almost there. Okay, stop. Frame by frame now. To proximal.
Just there.
Just there. Probably this is the wire. Proximal. This is the wire. You can see at 12 o'clock. Some struts, probably a couple of struts in the left main, and this is the left main.
The problem
so we can measure there probably again to confirm this is 5.
The problem is now the image is enough good, no?
Okay.
The image is good. The ostium is improved respect to previous IVUS, no? That's the question is stent now?
I think so, because you have dilated the left main, and
yeah, I think
without a stent or a drug-eluting balloon in some cases, we know that only POVA in the left main is not an option in this case. Danny?
No. We are doing the measures. I am still thinking that the left main is 5.
Is 5. Okay, let's put a stent. So no, probably a 3.5 by 16. We got it. The stent. Yeah.
Laura, what is the reference diameter 1 millimeter
Un segundo, Patri, un segundo.
distal to the ostium? Can you please?
Because Guillermo is thinking to put a 440 stem.
Yeah.
Sí. I read the mind of my colleague and my friend. He's thinking of putting a 4.0 stand there. I don't know. I don't know. The diameters, as you have seen, is 4 by 2 point something. Probably 3.5 is a.
Yes.
Yeah.
And
Is that
Let's go. Patri, danos el 3.5. We are going with the 3.5 by 16. And this is the crucial part, one of the crucial parts of the procedure to plug the stand properly and see the effects in the side branches. We have a trifurcation here. The ostium of the circ is good. The ostium of the intermediate branch has some disease, but without any functional impairment at the beginning of the procedure. We don't know after the stent. Okay. I'm going to wash the wire a little bit. Let's go.
Danny.
yes?
In the chart, which is the maximum diameter of this stem, please? The chart.
¿Tienes?
3.5.
I think you can go up to 5 point
5
something.
5.0 maybe.
And probably in bench studies, they go up to 5.6, if I remember well. Well, okay. Carmen, tengo la que. Let's be focused on this part because we have to implant the stent.
Yeah, up to 5, I think. 5 is the maximum diameter.
Let's go. Let's focus here. Ok, Carmen, te voy a pedir test, ¿vale? Vale, test, por favor, rellenamos y luego hacemos un cine. Vale.
Más o menos ahí, ¿eh?
¿Cine?
So they should be on at 11 and in that room from 11 until they finish the case.
Ok. ¿Os gusta este? Vamos a pasar de eso. Vamos, Philip, we need to be focused here, okay? ¿Vale?
Okay.
Venga, arriba.
Voy. I'm going 16. 16 is 3.195, 16.
Okay, with expansion, okay, go down. As you have seen, we have enough length in the left main to do a pot with a 0.0 balloon. Okay. Direct here, please, a little bit. The overlapping segment. Blood pressure is okay. The patient is okay.
12.
Okay.
Nominal.
Okay. Go down. Let's go with the stand.
Vale, que sacarlo.
Dame una
Bueno,
jeringa.
ya está casi. Ya está casi. Ya está casi.
Okay. Test, por favor, antes de irnos. Okay, quite good. The intermediate branch has increased the size a lot after the PCI.
NC 5.0, please.
By 8.
By 8. 5x8 de NC.
So you need to remember this key point that is the pot. Always do pot and pot and pot in this kind of bifurcations. Probably is most important that do the kissing. So we're going to perform the pot and then do some measurements and decide what can we do or what we need to do with the branches.
¿Qué ha dicho Philip? ¿Qué ha dicho?
Te la estoy poniendo, no está en el tronco. Probablemente que tenemos que estar aquí hasta las 11.
Philip, can you repeat our comment, please? Your comment?
Venga, vamos aquí.
Yeah.
Sorry about that, guys. I just unmuted by accident. It wasn't related to the show.
Okay, let's go with the pot.
5
Yes,
millimeters
5 by 8.
by 8. Yeah.
You always need to remember to leave length enough in the left main in the proximal main vessel to do the pot. Okay, come on. No sé si está en bus o va a haber algo. Está en bus, please, ¿me ponéis?
Ujú.
Espérate que hagan
Vamos a
en bus.
intentarlo.
Con el resynchro no sé si va a haber.
Es mejor.
Tienen vacío.
No, vamos, lo podemos intentar a ver.
Bueno, si no lo...
Sí, lo podemos nosotros ahí.
Sí, tienes razón.
Herramientas coronarias, ¿no?
Sí, sí.
Coronary tools, yes.
No, but it's... No, okay. Let's go in to do it with a thin without contrast, okay? A bit more proximal, probably.
Yes. Para que lo veas,
Me mareas.
para que lo veas mejor. Es que si no, bueno, pues hacerlo.
A ver. Respira despacito, por favor, ahora. Venga. I am there, I think.
Yes.
Okay, let's do. Nominal, okay?
Okay. 12
Okay, down,
nominal.
down. See, in this projection, the intermediate branch is overlapped. It's difficult to see the origin, but we know it by the IVUS. I'm going to retrieve the balloon. Slowly. Test, please. Test. Okay, everything is open. Let's retrieve the balloon, do some angios, and then repeat the IVUS and the functional test.
Ahora la había bien, ¿no? Ahora lo va bien, aquí está.
Sí. Sí, veo que... Okay. The balloon is out. Okay, perfect. Vale, vamos a rellenar aquí un poquito.
Vamos muy bien. Vamos muy bien.
Ok.
Vale.
Vamos a poner un poquito más de caudo. Let's do a thinning here. ¿Preparados? Venga, thinning. It's quite good. Vale. Hacemos un TCA.
IVUS.
Let's do the spider and then an IVUS. Sí, dame para TCA que me preocupa. We are checking again and again the heparin.
I think the angio is perfect. Now we are going to see the
IVUS will
IVUS.
tell the truth. Okay. No question, Danny?
No question.
Okay. Let's do the spider. Blood pressure is perfect. I don't know if we can move a little bit to move the lead. I don't know why I can move the...
Vamos así hasta que hagamos.
meter the lead is probably there. ¿Cine aquí? ¿Cine? Okay, I think the circ is quite good. The left main LED is quite good. We see a slight impairment of the stenosis of the intermediate branch, and we have the gel wire there. Let's check the LED. That is the most important part. Ah, it's here. Okay. ¿Pilláis la guía, Guille? ¿Tienes? Ok, suelta. Vale.
A la mitad de los stents, yo creo, porque el otro ya lo chequeamos y no lo hemos vuelto a tocar.
We're going to check the proximal stent because the previous stents were checked before in the last pullback. Probably there.
More distal.
Okay. More distal.
A little more. I think yes, because
Okay.
yes. Perfect.
Pullback.
It's very good.
These are the previous one, I think. Yeah. This is the MSA. Slight under expansion previously, but I think is the area is quite good. We are reaching the proximal part. We can measure after that. This is the wire.
This is the left main.
And the left main. Let's see the position. Probably is quite good. Okay. Okay. Let's check again the run. The proximal part. The proximal part. I don't know if we need to pause dilate a little bit or not.
Left main. The pot.
Yeah. 240.
Frame a frame.
Ponle 2000.
The pot frame a frame, please.
This is the wire. I think the position is quite good. Okay, a very short left main. No, it's not a perfect circumference, but I think the area is quite good. Okay, perfect.
Yes,
I think the left main LED is almost done. So we can check the DFR in the jail wire, ¿no? Venga. Dame el cacharrito de la guía de presión.
Eso es.
Que creo que es esta. Sí.
Bajar un poco el conector.
No, igual se conecta bien.
Pueden conectar.
A ver. So you know that the Comet wire, one of the advantages is that the connection and disconnection is easy. You can see it. Some impairment. Okay. Let's do the DFR when it's stable. I don't know if it's increasing the value. Let's wait a little bit if we reach 0.89. But I think it's stable there. Do the measurement, please. Okay, let's do another one. Okay. third one to no.
That is the
No, but you need to remember
the
we're
one is the
going to discuss it now.
Okay.
But remember, this is not white or black. We have a measurement in the threshold of treating the branch, but this is the branch, and if we treat it, we are going to dilate through the stent in the left main. We can do it. We have drug-eluting balloon as well, but we need to consider everything in this patient. Okay. I'm going to do a pullback. Okay, watching the PDPA. This is the wire. Okay. Okay. What's the DFR value and the PDPA? Because I'm going to go back with the wire, with the gel wire that is not quite gel because of the pot. I'm going to put slightly distal to the ostium. It's the same value probably. I am look on the agio. I'm there.
Change. Yes.
This is changing, no? So
Yes.
probably I was too far. We need to measure again, please, the DFR. We're going to do a test just to check I am not in the left main now. I'm going to advance a little bit to be sure I am the branch, not in the left main. There, I'm sure I'm the branch. This is like a little lower. This is the point.
Yes. Yes.
This is the point.
Yeah.
It's in the threshold. 0.89, 0.90, 0.87. It depends the half a millimeter advancing or retrieving. Okay. I'm going to pull back the wire and trying to advance again. I don't know if, let's see if the drift is okay. You can see here 0.98 more or less. I'm in the guiding. Yeah, it's good. So I'm going to retrieve the wire and trying to advance again. I don't know if I can do it without the torque, but I will try.
Okay.
I'm there. Yes, please.
I think this is,
Or is it circ?
Reflex, no? Yeah.
Is it circ?
Now it's good. Very good.
I don't know. Yes, please. It's a small branch. It's a small branch. A mí no,
¿Quieres el rotor?
no puedo porque tengo el... Bueno, puedo, pero ya está. A ver.
No, es...
Lo que quiero es que me cojas esto en la mano.
Hay que rotar un poco, ¿no? Ahí nada más entrar.
No, it's a small branch, a small invisible branch. Look.
Tiene que ponerse la punta como para otro lado.
Sí. Yes, please. It's a branch. It's a small branch. Always the same one. I have to enter in another position. Yes, please. The lead of the device is not helping me to see anything.
Podemos usar el rotor y luego volver a conectar, ¿no?
I'm there. Okay. Okay. So I have to recross again. I'm going to retrieve a little bit to the proximal part of the intermediate branch, probably here. Sí, vamos a ponerle, Daniel, remember me that we have contrast here is a control FFR, that you know the threshold is different. It's probably the contrast FFR 0.83 or something. We have to wait some minutes to wash all the contrast in the microcirculation. You can see the DFR value on the PDA is going to increase slowly. So while we wait, we need to decide if we are treating this ostium, even if the DFR is pathologic, and modifying the stent in the left main.
Yeah, that's the point, no?
I think the ischemia is not critical because we have a value of DFR of 0.83, 0.90, depends the value is
And
in the threshold.
If we do the FFR with adenosine, or
We can do it.
because
We can
No,
do it. I
because
don't
it's-
remember
it's
that
liquid, no?
Danny asthma or something like that.
No.
No. ¿Nos podéis dar adenosina intracoronaria, por favor? Guillermo is saying that we can do another measurement with FFR, with intracoronary adenosine. I think we have enough time. Let's check the last angio.
Yes, it's
The circ is quite good. In my point of view, I think I will be conservative with this lesion.
I
Danny.
think that the point is the median artery stent has some intrastent restenosis. Maybe treating just the stent, not the ostium, the DVR could be negative.
The intermediate branch has no stent. You mean the native? No,
No.
I don't think so.
Okay, no. Yeah, maybe.
But probably there's a stenosis there.
Yeah.
I agree with you.
Yeah.
But I don't know the pullback. When you do the pullback, the
It's just
the point is the
ostium.
ostium. The point is the ostium.
The problem is the
But is the thing I was saying before. This is not black or white. That some colleagues of us said no, it's 0.88. We need to treat it. It's 0.90 or 91. Yeah. We don't need to treat it. And in this case, probably the ischemia is not the patient. It's asymptomatic. We need to remember it. The ventricular dysfunction is multifactorial, probably. So let's do that. Vamos a poner una medicación. Puedes notar alguna sensación rara unos segundos, ¿vale? Si te decimos que toses, ¿vale? Sí, le ponemos un tercio de Fenta, porfa. Estamos terminando ya, ¿eh? Sí, lo sé, es incómodo. Bueno, vamos a hacer FFR, ¿vale?
FFR, please.
Ok. Let's watch the EKG. I'm going to start. There's some bubbles here. Okay. Slowly. 60 micrograms. Look the ECG and the pressure. 120. I think 200 is okay.
Washing?
Water, yeah. A little bit more, please. Okay. Let's check. Lara, when there's... Okay, I think we can measure now. 0.7. So below the original values of FFR, the deferred trial, and what do you think? We can do a dilatation of the ostium with a small balloon and then drag a lutein balloon with a kissing.
I think so, because in this patient is a young patient with left ventricular dysfunction, I think.
Dame un balón de 1,5 10 o así.
Incluso más, ¿eh? Esto es gordo, ¿eh? Es gordo.
No, para que pase los extras, digo.
Pasa muy bien la guía.
Dos, también dos. Un balón de 2.
2.0, sí, 2.
So,
cortito, 12 como mucho, ¿vale?
Sí, we're going to mark, dame el rotor, por favor. ¿Qué hora es?
Menos 10.
Sí. Pero no importa, esto ya...
Ok. You are seeing the screen of the FFR value. There is also a controversy of believing more in non-hyperemic indexes or in FFR. And in these cases, with a value near the threshold, knowing all the measurements can help to decide. Pero hay que pensar en el siguiente. Gracias. Ok. No, vamos a terminar el caso bien. ¿Tenéis la guía, por favor? Espera, que es que tengo poca guía metida, ¿eh? Espera. Un segundito.
Así.
¿Me dais un test, por favor?
Ya está. Está bien.
Ok. ¿Está bien?
Sí.
¿Tengo yo?
Vale. Bueno, son un lineaje, esa es la puta, pero bueno.
Ahí está. Let's see the balloon cross. It has crossed, no?
I think so.
Okay. One second only. 1 second. Ok, test, Carmen, por favor. Hay mucha agua, ¿vale? Ok, I think we are there. Ok.
18.
Ok, go down.
Y hay que darle un poco más atrás, porque
Sí.
estamos un poquito dentro.
The problem is to damage the circ as well with these dilatations. I don't think so, but vale, más proximal. If you have seen the IVUS, probably we have 5 millimeters or so in the left main. Okay, down. Okay. Test, por favor.
Con esto, pues eso está suficiente, ¿no?
I'm not sure that the wire
Sí.
now has crossed through the stem or distal to the stem. Let's do a cine. And let's think about the result. If we need a drug eluting balloon, is if it's enough. If we need a kissing, let's see. Probably with this small balloon, 2.0, the stem in the left main is not damaged. Contraste, por favor, que habrá agua. Okay. Indeed, I think I have crossed outside the stent. You know, the branch is a little bit distal to the stent, and probably we have not crossed through the stent. You see? We can know it by IVUS.
Dices que no hemos cruzado por el STAT.
No lo sé. Si la segunda guía pasa o no por dentro del STAT. Let's measure the DFR again. We know that
Ponemos el IVUS.
Déjame la guía de presión un segundo. The measurement of the functional measurements after a PCI are not always a good thing because it's difficult to interpret the results. ¿Me dais agua, por favor? ¿Rellenáis con salino? Salino. Ustedes cuenta, ¿no?
El problema es que, claro, era un 2 y el vaso es más grande. A lo mejor no hemos dilatado. La impresión es que no hemos dilatado bien ahora. Si está por fuera, no lo sé. Te pasa muy fácil. Me parece extraño. Pero quizá deberíamos hacer IVUS, ¿no? Para ver si estamos
Mira. Similar than before, ¿no? The DFR. It's similar than before. After a PCI, I'm not sure how to interpret the.
I think it's better, no? Because it's
a little bit better. The waves are better than before.
Yeah.
We have now a DFR of 0.90. We can store this, please. Probably the result is nice, and I would use the IVUS through the LAD just to check the stent is okay. Because if the stent is okay, we have finished.
Yeah.
Okay.
Yeah, I think so.
So we have a normal value or the value over the threshold in the left main, in the intermediate branch. So we are going to check if the stent in the left main LAD is okay after this dilatation with a small balloon. And if it's okay, I think we are done. El IVUS aquí.
Sí, esa sí, porque ha mejorado. mejorado la isquemia.
No, the angiographic image in the intermediate branch is better. The value of the DFR is better.
If we use a bigger balloon, probably we will have dissection and
not only dissection, but also the formation of the stent. No? We are not sure of having crossed through the struts, or if just the origin of the intermediate branch is a little bit inside of the circ is indeed a marginal. Okay, let's go. Let's go.
very good.
Suficiente,
¿no?
Sí, no, yeah. Okay. Probably here is enough. Live. Okay.
Vale.
We are in the proximal LED now in the IVUS, if you can see it. This is the wire.
Yeah.
And the stent is, I think it's okay. Okay, we can check it slowly. We can check this pullback. That's the proximal part.
Stop.
The distal.
At wire level.
Distal. No, probably south the stem, the wire. No, probably. Proximal. Let's see if it enters inside the stem or not. Probably it's outside the stem all the time. It's a good part.
I'm not sure.
I'm not sure, but the stem is okay. So I think we have finished now. We can do a final angio. I don't know if we did it after the dilatation of the. Yes, this is the final one. I think we don't need any other projection. We can use the spider if I can, and we are going to finish the case. If there is no question in the audience, probably here. Okay. Relléname con contraste, por favor. I'm going to retrieve the wires. Okay. Venga. ¿Tiene?
Nice.
I think it's quite good. Okay. Let's go. So thank you for your attention, and we see you later in our second case. Bye-bye.
Thank you very much.